Hello and welcome. If the C790 OA exam has been on your mind and you're wondering how to approach it, then you're in the right place. Our website has C790 OA questions and answers, and it won't cost you a thing. OA exams are tough, so everything from guides to practice questions is free. With over 100 plus success stories, we have proven our videos will help you pass your exam on the first attempt. In this video, we will cover questions from open versus closed systems, GIGO system, entropy in systems, EHR implementation, workarounds. So, let's get started.
Question 1. A health system implements an electronic health record that exchanges patient data with external reference laboratories, retail pharmacies, and a regional health information exchange. Incoming results update clinician dashboards in near real time. Which classification best describes this platform? Your options are A closed system because the EHR maintains its own internal patient database. B, an open system because the platform exchanges information across its boundary with the environment. C, a target system because each workstation operates as an independent unit of analysis. D, a super system because the EHR oversees all downstream clinical applications. Which one is it? Pause the video if you need more time. The correct answer is B, an open system because the platform exchanges information across its boundary with the environment. B is correct because open systems sit inside a semi-permeable boundary and actively exchange information, matter, or energy with their environment. The EHR pulls in lab results, pushes prescriptions, and sends data to an HIE, which is textbook bi-directional exchange across the system boundary. A is wrong because closed systems are sealed off from environmental exchange. An EHR that depends on outside data feeds and pushes information out cannot meet that definition. C is wrong because a target system is whatever system an analyst has chosen to focus on at a given moment, not a description of openness. The label does not capture the data exchange behavior. D is wrong because a supersystem is the larger structure that surrounds a target system, such as the entire hospital enterprise around a single application. The scenario describes exchange behavior, not hierarchical position. Every system in healthcare, from a bedside monitor to an entire hospital, is defined by a boundary. The critical question is whether that boundary lets anything cross it. An open system runs on a continuous loop. It takes inputs, transforms them, produces outputs, and relies on feedback to stay aligned with its environment. Remove any one step and the system slowly drifts out of phase. An electronic health record is a textbook open system. Lab results and outside records flow in, clinical decisions flow out, and feedback, like medication alerts or usage analytics, loops back to improve the next cycle. A closed system lets nothing in or out, theoretically stable, but practically useless in healthcare. The moment an EHR sends a prescription or pulls a lab result, it is behaving as an open system. In healthcare, closure is almost always a sign something is broken. When a question describes data crossing a boundary in any direction, that system is open. Openness is not chaos. It is the entire design goal of health information exchange, and recognizing it lets informatics leaders plan security, capacity, and governance correctly. Question 2. A nursing informaticist reviews a quality dashboard built from EHR documentation and finds that 4 risk scores are missing or miscoded for nearly half of admitted patients. Downstream reports based on these scores show inconsistent fall prevention compliance trends. Which system's theory concept best explains this dashboard problem? Your options are A, equifinality because different units use different documentation pathways. B, negentropy because the system is becoming more organized over time. C. Garbage in, garbage out, because flawed input data produces unreliable output. D. Specialization, because subsystems have evolved their own documentation rules. Take a second. Which answer would you pick? The correct answer is C. Garbage in, garbage out, because flawed input data produces unreliable output. C is correct because garbage in, garbage out, abbreviated GIGO, captures the principle that the quality of a system's output is bounded by the quality of its input. Incomplete or miscoded full risk entries at the point of documentation directly produce the unreliable dashboard the scenario describes. A is wrong because equifinality describes the tendency of open systems to reach the same end state through different paths. It does not explain why the data feeding the dashboard is unreliable. B is wrong because negentropy is the tendency of living systems to grow and become more organized. Missing and miscoded data is the opposite of growing organization. D is wrong because specialization describes how subsystems develop distinct purposes as they mature. While unit-level differences may contribute, the core problem is poor input quality producing poor output, which is GIGO by definition. GIGO is one of the oldest and most important principles in information processing. It tells us that the quality of any system's output is strictly limited by the quality of its input. No amount of clever analysis can fix problems that start at the point of data capture. Once bad data enters a pipeline, it does not stay contained. Errors propagate through every calculation, filter, and summary stage that follows. By the time a problem reaches a dashboard, it may have been multiplied across dozens of records, making the original defect nearly impossible to spot. The chain has 3 zones, where data is captured, where it is processed, and where it is displayed. A common mistake is blaming the dashboard or the report logic when something looks wrong. GIGO teaches us to walk the chain backward all the way to where the original value was entered. The most powerful application of GIGO is as a design principle. Teams that take it seriously invest in structured fields, input validation, and mandatory entries that cannot be silently skipped. Catching errors at the source is always cheaper than cleaning corrupt data after it has traveled through an entire analytics stack. When an informatics report shows unexpected patterns, resist the urge to blame the analytics layer. If documentation fields are ambiguous or being worked around, the dashboard is doing its job perfectly. It is just reflecting bad input. GIGO reminds us that beautiful visualizations cannot redeem data captured poorly at the source. Question 3. A clinical informatics director observes that an aging order set library has accumulated duplicate entries, broken decision support links, and outdated dosing references over the past several years. Without active maintenance, the library is degrading toward disorder and becoming less useful at the point of care. Which systems theory characteristic does this trend represent? Your options are A. Entropy, the tendency of a system to break down into its simplest parts over time. B. Equifinality, the ability to reach the same end state through different paths. C. Reverberation, the unintended downstream consequences of a system change. D. Dynamic homeostasis, the process of maintaining a steady state in the system. Before I reveal it, which one do you think is right? The correct answer is A. Entropy, the tendency of a system to break down into its simplest parts over time. A is correct because entropy is the tendency of all systems to wear out and break down into simpler, more disordered states without the input of energy. A neglected order set library that accumulates duplicates, broken links, and outdated content is exhibiting exactly this drift. B is wrong because equifinality is about multiple paths to the same end state in open systems, not about decay. It does not describe a deteriorating order set library. C is wrong because reverberation refers to the intended and unintended consequences when a system change is introduced. The scenario describes neglect, not the rippling effects of a deliberate change. D is wrong because dynamic homeostasis is the process by which a system maintains balance through ongoing adjustments. The order set library is failing to maintain balance, which is the opposite condition. Entropy is the tendency of any system to drift toward disorder when no energy is invested to maintain it. Borrowed from physics, this concept applies just as powerfully to organizations, software, and clinical tools. Picture an order set library built carefully at go live, without a defined owner and review cadence. New medications accumulate alongside old ones. Outdated guidelines linger as defaults, and clinicians stop trusting the tool entirely. That slow descent is entropy in clinical informatics form. It helps to contrast entropy with its neighbors. Dynamic homeostasis is the active work of staying balanced, and negentropy describes living systems that grow more organized. Both require ongoing energy input. Entropy is simply what happens when that energy stops. On exam day, the signal is a system that was once functional and is now degrading without active intervention. Watch for phrases like stale content, broken links, duplicate entries, or clinicians ignoring a tool. Distractors like reverberation and equifinality describe very different phenomena. Entropy is not a failure of intent. It is a property of all systems, and nursing informatics addresses it through governance, defined ownership, regular review cycles, and retirement criteria that keep clinical tools trustworthy over time. Question 4. 2 community hospitals adopt different vendor EHRs, follow different implementation timelines, and rely on different training models, yet both reach a similar level of CPOE adoption and clinician satisfaction within 2 years of go live. Which systems theory concept best describes this outcome pattern? Your options are A. Negentropy, because both hospitals became more organized after implementation. B. Reverberation, because each implementation produced unintended consequences. C. Specialization, because each hospital developed its own subsystems. D. Equifinality, because open systems can reach the same end state through different paths. What's your answer? Commit to one before I continue. The correct answer is D. Equifinality, because open systems can reach the same end state through different paths. D is correct because equifinality is a tendency of open systems to arrive at a characteristic final state from different starting conditions and through different routes. 2 hospitals reaching similar CPOE adoption through different vendors. Timelines and training is the textbook pattern. Is wrong because negentropy describes growing organizational complexity and order, while both hospitals may exhibit this. The question targets reaching a similar end state through different paths, which is equifinality. B is wrong because reverberation focuses on intended and unintended ripple effects of change. The scenario emphasizes outcome similarity, not ripple effects. C is wrong because specialization describes how systems divide into subsystems with distinct purposes as they grow. The question is about end-state similarity across 2 organizations, not internal differentiation. Equifinality is one of the most practically useful properties of open systems. It tells us that very different organizations, starting from very different places, can still arrive at a similar outcome. The principle has 3 moving parts: where you start, how you travel, and where you land. Equifinality says the first 2 can vary widely without preventing you from reaching a comparable destination. The mechanism works because open systems exchange information with their environment and self-correct through feedback. A hospital short on capital but rich in clinical engagement can substitute clinician energy for dollars. Another hospital reverses that trade. Both can land at comparable performance. Watch for 2 frequent distractors. Reverberation describes ripple effects spreading through a system. Negentropy describes a system growing more organized over time. Neither captures the convergence pattern. When a question shows two organizations diverging in method but converging in outcome, equifinality is the name concept. For nursing informatics leaders, equifinality is permission to build implementations that fit your own organization rather than copying someone else's playbook. The neighbor who took a different route and still landed well was not lucky. They were running an open system that found its own way. Question 5. After deploying a new electronic medication administration record, a hospital observes faster bedside scanning compliance. But pharmacy reports a sharp increase in stat order verifications, and the help desk sees a surge in single sign-on tickets across unrelated applications. Which systems theory concept best characterizes this pattern of related and unrelated downstream effects? Your options are A. Entropy, because secondary systems are degrading after the change. B. Reverberation, because system change produces both intended and unintended consequences. C. Equifinality, because all departments are converging on the same end state. D. Dynamic homeostasis, because the organization is maintaining a steady operational state. Pick one. Trust your gut. Here's your chance to test yourself. The correct answer is B. Reverberation, because system change produces both intended and unintended consequences. B is correct because reverberation describes the intended and unintended consequences that ripple through related and seemingly unrelated parts of an organization when a system changes. Faster scanning is intended, while stat order spikes and SSO tickets are unintended downstream effects, all flowing from the EMAR change. A is wrong because entropy refers to a system breaking down toward disorder, not to the ripple effects of a deliberate change. The scenario describes consequences of an implementation, not gradual decay. C is wrong because equifinality concerns reaching the same end state via different paths. The scenario describes diverging effects across departments, not convergence. D is wrong because dynamic homeostasis is about maintaining balance through ongoing adjustment. The hospital is dealing with active perturbations, not demonstrating steady state preservation. Reverberation is the systems theory concept that explains why changes in one part of healthcare system send ripples into parts that seem completely unrelated. It gives us language for something every implementation leader has already lived through. The word itself captures the idea. A single local disturbance creates waves that travel outward through every connected surface. In a hospital, that ponders a dense web of shared identifiers, interfaces, workflows, and clinician attention. Because healthcare systems share so much infrastructure, pressure from one change travels along every connection. Some downstream effects are anticipated and managed. Others surface days or weeks after go live, long after the project team has moved on. This is where exam questions try to trip you up. Reverberation is not just direct cause and effect. It covers the full spectrum of downstream consequences, even when the causal chain is murky, but the timing points back to the implementation. For informatics teams, reverberation means go-live monitoring must extend beyond the target system. Build cross-system communication early, and treat unexpected downstream effects not as noise, but as a predictable phase of every implementation. Question 6. A health system leader describes the inpatient nursing workforce as a network of autonomous teams that learn from daily patient assignments, share lessons across shifts, reorganize staffing as census shifts, and continuously adjust to new clinical guidelines and population health pressures. Which framework best describes this workforce? Your options are A. A complex adaptive system whose agents learn, self-organize, and co-evolve with the environment. B. A closed system whose boundary protects it from external influences. C. A simple system in which cause and effect are directly observable. D. A waterfall system in which each phase must complete before the next begins. Which would you go with? Lock it in before the reveal. The correct answer is A. A complex adaptive system whose agents learn, self-organize, and co-evolve with the environment. A is correct because a complex adaptive system, or CAS, is composed of diverse autonomous agents that learn from experience, self-organize, exhibit distributed control, and co-evolve with their environment. The nursing workforce in the scenario shows every one of those traits. B is wrong because closed systems are walled off from environmental exchange and do not adapt. Nursing teams responding to census, guidelines, and population pressures are clearly exchanging with their environment. C is wrong because a simple system has clear, directly observable cause and effect. Workforce dynamics with self-organization and co-evolution are far from that profile. D is wrong because waterfall is a software development lifecycle approach with rigid sequential phases, not a description of human social systems. A complex adaptive system, or CAS, is a collection of diverse autonomous parts that are interconnected, behave as a unified whole, and continuously learn from experience. This framework, borrowed from biology, helps us understand organizations like healthcare that resist simple mechanical control. Every CAS shares a handful of recurring properties. Control is dispersed, not centralized. The system never truly settles. Agents constantly learn, self-organize, and co-evolve alongside a shifting environment. Traditional management treated organizations like machines. Input X reliably produces output Y. But in healthcare, that model kept failing. A CAS lens replaces that straight line with a web of intelligent, adaptive agents whose interactions produce emergent, sometimes unpredictable outcomes. Think of a large inpatient nursing workforce. Hundreds of nurses make thousands of micro-decisions daily. Charge nurses self-organize staffing in real time, and the whole system responds to census shifts and new guidelines. No central authority could possibly direct every move. For nursing informatics, recognizing healthcare as a KS means deploying technology in waves, monitoring closely, and adjusting frequently. Tools that respect clinician autonomy and allow local adaptation consistently outperform top-down mandates in complex adaptive environments. Question 7. A nurse manager triages a routine help desk ticket that describes a clinician unable to print discharge instructions because the local printer is offline. The cause and the fix are well known and documented. Which Cynefin domain and response pattern best fit this situation? Your options are A. Complex domain, calling for probe, sense, respond. B. Complicated domain, calling for sense, analyze, respond. C. Simple domain, calling for sense, categorize, respond. D. Chaotic domain, calling for act, sense, respond. Don't overthink it. Which one feels right? The correct answer is C. Simple domain, calling for sense, categorize, respond. C is correct because the simple domain in the Cynefin framework covers highly ordered situations where cause and effect are evident and best practices apply. The recommended pattern is to sense the issue, categorize it against known patterns, and apply the standard response, which is exactly how a routine printer ticket should be handled. Is wrong because the complex domain involves emergent cause and effect that requires probing first. A printer outage with a known cause does not require experimentation. B is wrong because the complicated domain is for problems where cause and effect exist but require expert analysis. A standard printer issue needs categorization, not deep analysis. D is wrong because the chaotic domain demands immediate action because cause and effect are not discernible. A printer ticket is far from a chaotic situation. The Cynefin framework helps leaders recognize what kind of situation they're facing before choosing how to respond. One of its 5 domains, the simple domain, covers the most predictable, well-understood situations a leader will encounter. In the simple domain, cause and effect are obvious, and there is broad agreement on the correct response. Best practices apply reliably, and the right answer is already documented. Think routine help desk tickets or standard maintenance tasks. The recommended response pattern in this domain is sense, categorize, respond. The central move is categorization. Once you correctly match the situation to a known pattern, the right action follows almost automatically. Consider a clinician who cannot print discharge instructions because the printer is offline. The cause is known, the fix is documented, and any trained agent resolves it the same way every time. A textbook example of the simple domain in operation. On exam questions, signal phrases like routine, documented procedure, and clear cause and effect point to the simple domain. Don't confuse familiarity with simplicity. The true signal is consensus on the correct response combined with a stable, predictable cause and effect relationship. Question 8. During a hospital-wide network outage that takes down the EHR, scheduling, and bedside monitors at once, the incident commander has no time to analyze root cause before patients are at risk. Which Cynefin domain and response pattern best describe this moment? Your options are A. Simple domain, calling for sense, categorize, respond. B. Complicated domain, calling for sense, analyze, respond. C. Complex domain, calling for probe, sense, respond. D. Chaotic domain, calling for act, sense, respond. Got a guess? Lock it in. The correct answer is D. Chaotic domain, calling for act, sense, respond. D is correct because the chaotic Cynefin domain applies when there is no discernible relationship between cause and effect, and immediate action is required to stabilize the situation. The recommended pattern is act, sense, respond. A simultaneous outage of EHR scheduling and monitors fits this profile precisely. A is wrong because the simple domain assumes cause and effect are evident, and a standard response works. A multi-system outage with patients at risk is not standard. B is wrong because the complicated domain assumes time exists for expert analysis to find the right answer. An active patient safety crisis does not allow that pause. C is wrong because the complex domain calls for small probes to learn from emergent patterns. A safety crisis demands immediate stabilizing action, not experimentation. The chaotic domain is the most demanding context in Cynefin. It describes situations where cause and effect are completely unclear, analysis is impossible in the moment, and immediate action is the only viable response. The prescribed response pattern in the chaotic domain is act, sense, respond. Action always comes first, not analysis. The leader does something protective to stabilize the situation, observes what changed, then chooses the next step based on new information. This is the critical distinction. Complicated situations have a knowable answer that careful analysis can reach. Chaotic situations have no discernible cause and effect at all in the moment. Treating chaos like complication wastes the one resource the situation does not have: time. In healthcare informatics, the chaotic domain appears when the EHR, monitoring systems, and scheduling collapse at once while patients are mid-treatment. Pre-built downtime procedures and designated incident commanders represent the act layer, built in advance precisely because there will be no time to design a response in the moment. Once decisive action restores a baseline of stability, the situation may shift into the complex or complicated domain where thoughtful analysis can begin. The discipline is keeping those two phases completely separate and matching your response to the domain you're actually in. Question 9. A health system rolls out a new clinical decision support alert intended to reduce sepsis mortality, but early data show inconsistent clinician responses and no clear pattern explaining when the alert is helpful versus annoying. Which Cynefin domain and response pattern best fit this scenario? Your options are: A simple domain calling for sense, categorize, respond. B. Complex domain calling for probe, sense, respond. C. Chaotic domain calling for act, sense, respond. D. Complicated domain calling for sense, analyze, respond. Which one is it? Pause the video if you need more time. The correct answer is B. Complex domain calling for probe, sense, respond. B is correct because the complex domain applies when cause and effect are not knowable in advance and patterns can only emerge through small experiments. Probe, sense, respond means trying small interventions, observing what happens and adjusting. A sepsis alert with inconsistent clinician response and no clear pattern is a textbook complex problem. A is wrong because the simple domain assumes cause and effect are evident with a known best practice. The scenario explicitly says the pattern is not yet clear. C is wrong because the chaotic domain demands immediate stabilizing action because no pattern exists at all. The alert situation is messy but not actively dangerous in the way chaotic situations are. D is wrong because the complicated domain assumes a knowable answer that experts can analyze. The complexity here is emergent behavior across many clinicians, not a hidden but solvable answer. The Cynefin framework describes 4 domains where problems live. The complex domain is where cause and effect cannot be known in advance. Patterns only emerge after you act, not before. The recommended pattern is probe, sense, respond. Probes are intentionally small, cheap, and designed to fail safely, so the system can reveal how it actually behaves without risking catastrophic consequences. On the Cynefin map, complex sits between complicated and chaotic. Complicated problems yield to expert analysis. Complex problems do not. They resist prediction, and action must come before understanding. The most common exam mistake is treating a complex problem as complicated. If clinicians respond inconsistently to a new alert and no clear pattern emerges from the data, long planning cycles will produce confident but wrong solutions. Complex systems generate patterns no one intended and no one could predict. The only path to understanding is to perturb gently and watch. In healthcare informatics, this is permission to deploy small. Learn continuously and let the system teach you. Question 10. A new chief informatics officer joins an organization in turmoil. Different leaders are giving conflicting accounts of the same operational problems. Factions are arguing over whether the issue is a workflow defect, a vendor failure, a staffing crisis, or a cultural breakdown, and no one agrees on which framework should guide the response. Which Cynefin domain best describes the situation the leader has walked into? Your options are: A. The disorder domain, where the dominant context is not yet recognized. B. The simple domain, where cause and effect are immediately evident. C. The complicated domain, where expert analysis can determine the answer. D. The chaotic domain, where action must precede analysis. Take a second, and which answer would you pick? The correct answer is A. The disorder domain, where the dominant context is not yet recognized. A is correct because the disorder domain describes situations where the leader cannot yet identify which Cynefin context dominates. So multiple perspectives compete and no single framework feels right. The way out is to break the situation into pieces and place each piece into one of the other 4 domains. B is wrong because the simple domain has obvious cause and effect with consensus on the right action. The scenario shows the opposite, namely confusion and disagreement. C is wrong because the complicated domain assumes experts can analyze the problem to find a knowable answer. The scenario shows that experts cannot even agree on what the problem is. D is wrong because the chaotic domain demands immediate action because no pattern exists. The scenario describes confusion about which domain applies, not a clear safety crisis demanding action. Beyond the four familiar Cynefin domains lies a fifth, disorder. Unlike the others, disorder is not a type of situation in the world. It is a state of the leader, a recognition that the dominant context has not yet been identified. Inside disorder, multiple people in the same room classify the same situation differently. One leader sees it as simple, another as complex, a third as chaotic. None may be entirely wrong, but their disagreement produces paralysis or contradictory action. The mechanism inside disorder is competing classification. The recommended response is to break the situation apart, examining each piece separately and placing it into one of the other four domains where an appropriate response pattern can be applied. The work of leadership in disorder is diagnostic, not decisive. First, name the condition explicitly. This alone can unlock a room where everyone is talking past each other. Then decompose the problem and place each component where it actually belongs. The most common mistake is treating disorder like ordinary complexity and applying a single framework to a mixed problem. The signal phrases to watch for are conflicting accounts, factions, and no agreement on framework. Naming disorder is often the most useful move a leader can make. Question 11. A nurse manager sends a verbal order clarification to a covering physician through a busy unit's two-way radio system. The transmission is partially garbled by background noise from a code response several rooms away, and the physician confirms an incorrect dose. Using the Shannon and Weaver model of communication, which element of the model best explains the breakdown? Your options are A. The encoder which converted the message into a signal. B. The destination, which is the final recipient. C. The information source which originated the message. D. Noise in the channel which distorted the signal between transmitter and receiver. Before I reveal it, which one do you think is right? The correct answer is D. Noise in the channel which distorted the signal between transmitter and receiver. D is correct because in the Shannon and Weaver model, noise is any interference in the channel that distorts the signal between transmitter and receiver. Background noise from a code response garbling a verbal order is the textbook example of channel noise corrupting the message before it reaches the destination. A is wrong because the encoder converts the message into a transmittable signal. The scenario does not indicate the manager misspoke or that the conversion to radio signal failed at her end. B is wrong because the destination is simply the endpoint receiving the decoded message. It identifies where the message arrives, not why it was garbled in transit. C is wrong because the information source originates the message before encoding. The scenario does not suggest the manager started with a wrong message, only that it became distorted in transit. The Shannon and Weaver model was built to explain how information travels through a transmission system, and more importantly, what goes wrong along the way. At the heart of the model is a concept called noise, which is the single most tested idea from this framework. The model traces a message through 5 stages. The sender originates an idea. The encoder converts it into a transmittable signal. The channel carries it. The decoder reconstructs it. And the receiver is the final destination. Noise is anything that distorts the signal between transmitter and receiver. It is structural. It belongs to the channel and the environment, not to the people at either end. That distinction matters. The sender's message can be perfect and the receiver's comprehension fine, yet the signal between them is corrupted. Noise takes 3 main forms. Physical noise includes background sound or static. Technical noise includes packet loss or corrupted file formats. Semantic noise involves jargon or ambiguous language the receiver does not share. Each type sits in the channel, not with either communicator. When a stem describes a garbled message, environmental interference, or a misunderstanding clearly traceable to transmission, the answer is noise in the Shannon and Weaver model. Recognizing where the breakdown lies are in the channel point you directly to the right fix. Question 12. A nursing informatics instructor describes Bloom's model of healthcare computing applications to her class. Which three categories does Bloom's original model identify? Your options are A. Empirical, ethical, and aesthetic. B. Data, wisdom, and metacognition. C. Data, information, and knowledge. D. Hardware, software, and peopleware. What's your answer? Commit to one before I continue. The correct answer is C. Data, information, and knowledge. C is correct because Bloom's model of healthcare computing applications identifies three categories, which are data, information, and knowledge. Later models such as Nelson's extended this continuum by adding wisdom, but Bloom's original framing was these three. A is wrong because empirical, ethical, personal, and aesthetic are categories from Graves's model, not Bloom's. They describe ways of knowing and nursing. B is wrong because wisdom is a category Nelson added to extend Bloom's model. Metacognition is not part of any of these healthcare computing models. D is wrong because hardware, software, and peopleware describe components of an information system, not Bloom's classification of healthcare computing applications. The Bloom model gives healthcare informaticists a precise vocabulary for describing what any application is actually doing. Rather than lumping everything under a vague label, it separates computing work into three distinct layers: data, information, and knowledge. At the base, data applications capture and store discrete elements, a lab value, a vital sign. Information applications take that raw data and organize it into meaningful patterns a clinician can interpret. Knowledge applications go further, encoding human reasoning so the system can apply it consistently at scale. Think of each layer as having exactly one job. Data is about reliable capture. Information is about meaningful presentation. Knowledge is about encoded reasoning that drives action, like a sepsis alert firing when a vital sign trend crosses a threshold. Exam questions frequently mix Bloom with two neighboring frameworks. Nelson later added wisdom on top of Bloom's three categories, creating the familiar four-part continuum. Graves and Corcoran used an entirely different set of terms. Knowing which author owns which vocabulary is the key to getting these questions right. Whenever a question names exactly three categories of healthcare computing applications, data, information, and knowledge, that is Bloom, any mention of wisdom points to Nelson, and any reference to empirical or aesthetic knowing points to Graves and Corcoran. Question 13. A doctoral student studying foundational nursing informatics models asks how the Nelson model differs from earlier work by Bloom, Graves, and Corcoran. Which extension is the defining contribution of the Nelson model? Your options are A. It adds the concept of empirical knowledge to the data continuum. B. It extends the data to knowledge continuum by adding wisdom. C. It replaces information with computer science concepts. D. It separates personal knowing from ethical knowing. Pick one. Trust your gut. Here's your chance to test yourself. The correct answer is B. It extends the data to knowledge continuum by adding wisdom. B is correct because the Nelson model extends the work of Bloom, Graves, and Corcoran by adding wisdom to the data, information, and knowledge continuum. Wisdom in this context means the appropriate use of knowledge to manage or solve human problems, which sits at the top of the hierarchy is wrong because empirical knowledge is part of Graves's work, not what Nelson added. The Nelson model focuses on extending the continuum upward toward wisdom. C is wrong because the Nelson model does not remove or replace information. It builds on the prior frameworks rather than discarding their components. D is wrong because distinctions between personal and ethical knowing belong to ways of knowing in nursing, separate from what Nelson contributed to the data continuum. The Nelson model of nursing informatics builds on earlier work by extending the classic data, information, and knowledge framework with a fourth and final category, wisdom. This addition completes the continuum that most nursing informatics curricula use today. Each step in the continuum adds something the level below it lacks. Data is organized into information. Information is interpreted into knowledge. And knowledge becomes wisdom only when a clinician applies it with judgment to a specific patient's context, values, and circumstances. Bloom's original model left the application layer outside the framework entirely. Nelson noticed that nursing practice depended on applying knowledge to particular situations, and that no existing model had vocabulary for it. Adding wisdom closed that gap. On exam day, whenever you see phrases like extending the continuum, adding a fourth category, or building on Bloom, Graves, and Corcoran, the answer is almost always the addition of wisdom. That single addition is what defines the Nelson model. Question 14. A nursing informaticist designing EHR training for experienced staff nurses preparing for an RCU module rollout chooses content that respects the learner's prior clinical experience, focuses on immediately useful skills, and centers self-directed practice. Which learning concept most directly guides this approach? Your options are A. Andragogy, the art and science of helping adults learn. B. Constructionism, the focus on relating new ideas to prior concepts. C. Pedagogy, the discipline focused on teaching children. D. Behaviorism, the focus on observable conditioned responses. Which would you go with? Lock it in before the reveal. The correct answer is A. Andragogy, the art and science of helping adults learn. A is correct because andragogy is defined as the art and science of helping adults learn. Its principles emphasize respecting prior experience, focusing on immediate relevance, and supporting self-direction, which is exactly the design choice the informaticist made. B is wrong because constructionism is about relating new information to previously learned concepts. While compatible with adult learning, the concept the question is naming is the broader framework of adult learning itself. C is wrong because pedagogy traditionally refers to teaching children. The scenario specifies experienced adult staff nurses, which calls for andragogy. D is wrong because behaviorism focuses on shaping observable responses through reinforcement. The scenario emphasizes adult-centered design, not stimulus response conditioning. Andragogy is the art and science of helping adults learn. A framework distinct from pedagogy, which was built around teaching children. Malcolm Knowles popularized this distinction in the 1970s, arguing that adults need their own design philosophy. Knowles identified recurring assumptions about adult learners. They are self-directed, experienced, and motivated by relevance. They want to know how new knowledge applies to their work right now, not someday. The contrast with pedagogy is structural, not just stylistic. Pedagogical design assumes a blank slate and teacher control. Andragogical design starts with what learners already know and centers on what they immediately need to do. In nursing informatics, andragogy shapes concrete design choices, training time close to go live, scenarios drawn from real workflows, and exercises learners can navigate at their own pace. When a question stem mentions adult learners, prior experience, or immediate relevance in a professional setting, andragogy is almost always the named concept. It is a disciplined design philosophy, not just a friendlier tone. Question 15. A nurse educator builds a sepsis simulation curriculum in which learners discuss cases in small groups, share interpretations of subtle vital sign changes, and refine each other's clinical reasoning. Which learning theory most closely describes this peer-driven approach? Your options are A. Andragogy, the science of adult learning; B. Behaviorism, learning through reinforced response; C. Constructionism, learning by relating new information to prior concepts; D. Social constructivism, learning that occurs through shared peer interaction. Don't overthink it. Which one feels right? The correct answer is D. Social constructivism, learning that occurs through shared peer interaction. D is correct because social constructivism emphasizes that learning happens through shared interaction with peers, where learners co-construct understanding by exchanging interpretations. A simulation curriculum centered on small group discussion and peer refinement is a direct application of this theory. A is wrong because andragogy is the broader science of adult learning. While the curriculum is for adults, the question targets the specific peer interaction mechanism, which social constructivism captures more precisely. B is wrong because behaviorism focuses on conditioning through reinforcement. Group discussion and peer refinement go far beyond stimulus-response shaping. C is wrong because constructionism, in this course's terminology, focuses on relating new information to previously learned concepts within the individual learner. Social constructivism specifically adds the peer interaction layer that the scenario emphasizes. Social constructivism is a learning theory rooted in the idea that a knowledge isn't built in isolation. It emerges through dialogue, collaboration, and shared interpretation with others. Unlike individual constructivism, this theory places the social context at the very center of how understanding develops. The theory rests on shared meaning-making. When learners exchange interpretations and challenge each other's reasoning, the resulting understanding is qualitatively richer than what any individual could construct alone. Productive disagreement is a feature, not a flaw. Visualize the contrast. Individual constructivism is a solo cognitive event, while social constructivism is a network of exchanges where the conversation itself becomes the site of learning, not merely a vehicle for checking what was already learned. In nursing education, this looks like small groups debating vital sign interpretations in a sepsis simulation, refining each other's clinical reasoning through exchange. The educator facilitates rather than delivers answers, because the group builds understanding no individual brought into the room. When a question stem describes peer interaction, group construction of meaning, or discussion that refines collective understanding, social constructivism is the named concept. Remember, a lecture to a room or parallel solo work doesn't qualify. What team were TDs? The defining feature is active exchange that produces shared knowledge. Question 16. A health system has decided to replace its legacy nursing documentation system before any new technology arrives. The project team holds listening sessions to surface frustrations with the current platform, shares benchmarking data showing how other hospitals have moved on, and coaches managers on why the old workflows must change. Using Lewin's three-stage change theory, which stage does this work represent? Your options are A. Refreezing, in which energy is spent stabilizing the new state; B. Unfreezing, in which the current state is destabilized to prepare for change; C. Moving, in which the planned change is actively implemented; D. Evaluating, in which post-change outcomes are measured. Got a guess? Lock it in. The correct answer is B. Unfreezing, in which the current state is destabilized to prepare for change. B is correct because unfreezing is the first Lewin stage, where the organization evaluates the current system and prepares people to let go of the existing state by surfacing dissatisfaction and the case for change. Listening sessions, benchmarks, and coaching conversations before any implementation are classic unfreezing activities. A is wrong because refreezing happens after the change is in place and focuses on stabilizing the new state. The scenario is happening before any new technology is deployed. C is wrong because moving is the active implementation of the planned change. The scenario describes pre-implementation preparation, not implementation itself. D is wrong because evaluating is not one of Lewin's 3 named stages. The activities described do not match a post-implementation outcome assessment in any case. Kurt Lewin's 3-stage change model, unfreezing, moving, and refreezing, is a foundational framework in organizational change theory. The first stage, unfreezing, is the most frequently misunderstood and most often skipped. Change moves through 3 stages. Unfreezing prepares the organization before anything new is introduced. Moving is implementation. Refreezing stabilizes the new state afterward. Each stage depends on the one before it. Inside unfreezing, leaders work with forces. Restraining forces hold the current state in place. Driving forces push toward change. Unfreezing weakens resistance by surfacing problems with the present, and strengthens momentum by building enthusiasm for the future. When the balance tips, the system is ready to move. Unfreezing produces no visible deliverables, no new system, no go-live date. Instead, it produces readiness. Signal phrases include preparing the organization, building the case for change, and surfacing dissatisfaction, all happening before any new technology or policy is announced. The common mistake is confusing unfreezing with the start of implementation. If a scenario describes pre-implementation preparation work, listening sessions, benchmarking, surfacing problems, that is unfreezing, not moving. Skipping it makes resistance in later stages far harder to overcome. Question 17. A nursing informaticist is leading clinicians through cutover week for a new barcode medication administration system. Builders are deploying configurations to production. Trainers are running just-in-time sessions on the floors. And super users are at the elbow of every nurse during their first shift on the new system. Using Lewin's 3-stage model, which stage does this period represent? Your options are A. Unfreezing, the destabilization of the existing state. B. Refreezing, the stabilization of the new state. C. Moving, the active implementation of the planned change. D. Maintaining, the post-go-live optimization phase. Which one is it? Pause the video if you need more time. The correct answer is C. Moving, the active implementation of the planned change. C is correct because Lewin's moving stage is the active implementation phase, when the planned change is being put into operation. Cutover week, with configurations going live, just-in-time training, and elbow support, is the textbook moving stage. A is wrong because unfreezing is preparation for change, surfacing dissatisfaction and building the case before implementation. The scenario is well past that point. B is wrong because refreezing is stabilization after the change is operating. Cutover week is the change happening, not the stabilization that follows. D is wrong because maintaining is not one of Lewin's 3 named stages. The scenario describes active implementation, which Lewin called moving. In Lewin's 3-stage change theory, the moving stage is the active middle phase, where planned changes actually happen. It sits between unfreezing, which prepares the organization, and refreezing, which stabilizes the new state. Unfreezing and refreezing are bookend phases. The real transformation lives in the middle. Moving is the stage when the organization is no longer at the old state, but has not yet arrived at the new one. It is in deliberate, managed motion. The engine inside moving is substitution. Old workflows, screens, and policies are each replaced by new ones. Every substitution requires people to actually do the new thing, often under pressure, often while still learning, supported by trainers, super users, and intensified help desk staffing. When a question stem mentions cutover, go live, configurations deploying to production, or super users actively supporting staff, that signals the moving stage. Remember, go live is the start of moving, not the whole of it. The phase continues through the entire active support period. The most common trap is treating moving as a single moment rather than a sustained phase. The moving stage spans the full period of active implementation, from the first go-live event through the immediate post-cutover window, when support is highest and new behaviors are being practiced for the very first time. Question 18. 6 months after go-live for a new EHR module, the Informatics team focuses on reinforcing the new workflows by updating policies, embedding the new screens into orientation, retiring legacy job aids, and rewarding consistent use through quality dashboards. Using Lewin's framework, which stage does this work represent? Your options are A. Refreezing, where the new state is stabilized and reinforced. B. Moving, where the plan change is being actively implemented. C. Unfreezing, where the existing state is destabilized. D. Reverberating, where unintended consequences are addressed. Take a second. Which answer would you pick? The correct answer is A. Refreezing, where the new state is stabilized and reinforced. A is correct because refreezing is the third Lewin stage, in which energy is invested to stabilize the change so that the new state holds. Policy updates, orientation embedding, retiring legacy aids, and reinforcement through dashboards are all classic refreezing activities 6 months after go live. B is wrong because moving is active implementation, which happened earlier during cutover. 6 months out, the focus has shifted from doing the change to making it stick. C is wrong because unfreezing is the destabilization that prepares people to change before any implementation. The scenario is far past that point. D is wrong because reverberation is a systems theory concept about ripple effects, not a Lewin stage. It does not describe stabilization activities. Refreezing is the third and final stage of Lewin's change model, the stage most often skipped. It's the deliberate work that converts a successful go-live into a permanently adopted change. Lewin identified 3 stages: unfreeze, move, and refreeze. Most implementation energy flows into the middle stage. Refreezing is what happens after go-live. And without it, the organization quietly drifts back to old behaviors. Refreezing works through embedding. The new state must be reflected in policies, orientation, rewards, dashboards, and culture, structural elements that hold behavior in place long after the active implementation team has moved on. A common exam trap is confusing refreezing with maintenance. Maintenance assumes the change has already taken hold. Refreezing is the active work that makes that assumption true, and skipping it is the most common cause of implementation regression. When a question describes post-go live work, updating policies, retiring old job aids, reinforcing through dashboards, that is refreezing. If the stem says the change is already stable and running smoothly, that is maintenance. Question 19. A health system rolls out an optional ambient documentation tool to its medical staff. Within a month, a small handful of physicians have built it into every encounter and are evangelizing the tool, while the broader staff is curious but waiting to hear how the early users fare. Using Rogers' diffusion of innovation theory, what term best describes a small group of immediate enthusiasts? Your options are A. Laggards, who adopt only after the innovation is universal. B. Early majority, who adopt once the innovation is established. C. Late majority who adopt under social or economic pressure. D. Innovators, the small first group eager to try a new idea. Before I reveal it, which one do you think is right? The correct answer is D. Innovators, the small first group eager to try a new idea. D is correct because Rogers' diffusion of innovation theory classifies adopters into 5 groups, with innovators being the small first group eager to try new ideas regardless of risk. Physicians who immediately build a new tool into every encounter and evangelize it fit this category. A is wrong because laggards are the last group to adopt, and only after the innovation is essentially universal. The scenario describes the first group to engage, not the last. B is wrong because the early majority adopts after the innovation has been established by earlier groups. The scenario is at the very start of adoption. C is wrong because the late majority adopts under pressure, well after the early majority. They are not the first enthusiasts the scenario describes. Everett Rogers' diffusion of innovation theory explains how new ideas and technologies spread through a social system over time. Rogers mapped the spread onto 5 distinct adopter categories, each engaging with an innovation at a different point in its life cycle. The classic diffusion curve is a bell shape. Innovators occupy the earliest, smallest slice, roughly 2.5% of the population. From there, adoption cascades outward through each successive group, driven not by the innovation itself, but by social influence flowing from one category to the next. Innovators stand apart because their motivation is internal. They do not need social proof to act. This makes them invaluable as early advocates and feedback partners. But their enthusiasm alone cannot guarantee that an innovation will cross to the mainstream. The mechanism is social proof cascading forward. Early adopters watch innovators, the early majority watches early adopters, and so on. Each group serves as the evidence the next group requires before they are willing to move. When a question stem describes the first small group to engage with something new, enthusiastic, undeterred by uncertainty, acting before anyone else, that is the innovator segment. The early engagement opens the door, but reaching the majority requires a completely different strategy. Question 20. A nursing informatics director preparing the organization for a major EHR upgrade structures the rollout plan around John Cotter's recommended conditions for organizational change. Which combination best reflects Cotter's recommended conditions? Your options are A. Refactoring and pair programming, B. Education and communication, along with participation and involvement, C. Inception, elaboration, construction and transition, D. Sense, categorize, respond. What's your answer? Commit to one before I continue. The correct answer is B. Education and communication along with participation and involvement. B is correct because John Cotter's recommended conditions for organizational change include education and communication, participation and involvement, facilitation and support, manipulation and co-optation, and explicit and implicit coercion. The combination listed is a direct match for the first 2 of these conditions. A is wrong because refactoring and pair programming are extreme programming practices for software development, not Cotter's organizational change conditions. C is wrong because inception, elaboration, construction, and transition are the 4 phases of the unified process software development methodology, not change management conditions. D is wrong because sense, categorize, respond is the recommended response pattern for the simple domain of the Cynefin framework, not Cotter's change conditions. John Cotter identified a set of structural conditions that any change effort must address to succeed. These aren't sequential steps. They're a planning checklist that change leaders use to avoid predictable failure points. The 5 conditions are education and communication, participation and involvement, facilitation and support, manipulation and co-optation, and coercion. Each addresses a different way that change efforts break down when leaders ignore the human and political realities of organizations. Think of these conditions as tools matched to where people are. Education builds awareness, participation creates investment, and facilitation builds capability. Manipulation and co-optation address political resistance, while coercion is reserved as a last resort when time or circumstances demand it. On nursing informatics exams, the most commonly tested conditions are education and communication, paired with participation and involvement. When a question stem describes a change effort struggling with staff understanding or buy-in, Kotter's framework and these 2 conditions in particular are the expected answer. A technically sound project plan that ignores communication, involvement, and support will still fail. Kotter's value is reminding change leaders to design for the human system, not just the technical one. Question 21. A health system kicks off a project to replace its emergency department information system. The first phase formally documents readiness, defines system requirements, maps current workflows, and identifies gaps between today's state and the desired future, according to the Staggers and Nielsen Systems life cycle model. Which phase is the team in? Your options are A. Analyze, where readiness, requirements, workflows, and gaps are assessed. B. Test, where extensive validation occurs before implementation. C. Implement, where the system goes live. D. Maintain and evolve, where ongoing updates are managed. Pick one. Trust your gut. Here's your chance to test yourself. The correct answer is A. Analyze, where readiness, requirements, workflows, and gaps are assessed. A is correct because in the Staggers and Nielsen Systems life cycle model, the analyze phase is the starting point and includes readiness assessment, feasibility determination, system requirements definition, workflow analysis, and gap identification. The work described maps directly to this phase. B is wrong because the test phase comes after development or purchase and focuses on validation of a built or configured system. The team in the scenario has not yet defined what to build. C is wrong because implement is the go-live phase. The team is at the very start, not deploying anything. D is wrong because maintain and evolve covers post-go-live updates and change requests. The scenario describes the earliest planning work, not steady-state maintenance. The Staggers and Nielsen Systems life cycle model is a phase framework for managing healthcare information system change. Rather than a simple loop, it moves as a spiral. Each cycle builds on the work of the last. The 7 phases move in order: analyze, plan, develop or purchase, test, implement, maintain and evolve, and evaluate. The spiral then returns to analyze, not mechanically to the start, but at a higher level informed by everything learned. Analyze is the entry point. It establishes readiness, feasibility, requirements, workflows, and gaps. Shortchanging this phase means building on incorrect assumptions about how clinical work actually happens, a costly mistake downstream. Plan translates findings into a commitment document. Develop or purchase produces a configured system ready for testing, not production. Test is the safety net before patients depend on the system. Implementation is intense and time-bound. Maintenance keeps it accurate. And evaluation feeds the next analyze phase. For the exam, when a question describes early project work involving readiness, requirements, workflows, or gap identification, the name phase is analyze. Test, implement, and maintain and evolve each carry their own distinct work. None of them belong at the discovery stage. Question 20. A government agency contracts for a public health surveillance system with fully defined requirements specified upfront The vendor follows a development approach in which each phase must complete before the next begins, with no return to earlier stages. Which SDLC approach best describes this method? Your options are A. Scrum, organized around short iterative sprints. B. Extreme programming, with pair programming and continuous integration. C. Waterfall, where phases are completed sequentially with no overlap. D. Walking skeleton, where bare bones end-to-end functionality is built first. Which would you go with? Lock it in before the reveal. The correct answer is C. Waterfall, where phases are completed sequentially with no overlap. C is correct because the waterfall model is the most predictive SDLC approach, with phases flowing down sequentially and no return to earlier stages once a phase is complete. Fully specified requirements and rigid sequential execution match this model precisely. A is wrong because Scrum is an adaptive Agile methodology built around short sprints and frequent feedback, the opposite of a rigid sequential flow. B is wrong because extreme programming is an adaptive Agile methodology emphasizing practices like pair programming, refactoring, and continuous integration. It is not characterized by no return to earlier phases. D is wrong because a walking skeleton is an adaptive technique that builds end-to-end functionality with minimal features early in the project. It does not describe a strictly sequential method. The waterfall model is a sequential approach to system development where each phase must be fully completed before the next one begins. It was designed to bring discipline and predictability to software projects through rigorous upfront planning. Each phase produces deliverables that the next phase consumes. Requirements and design are locked in completely before any code is written, and once the project moves forward, it cannot return to an earlier stage. Waterfall is not obsolete, it is situationally appropriate. Public health surveillance systems and regulated medical devices are examples where requirements can be fully specified in advance and stability is genuinely achievable. The metaphor captures the model's core constraint: momentum only moves in one direction. When requirements are truly stable, that one-way flow produces clean, well-documented systems on predictable timelines. The exam day signal phrases are sequential phases, fully specify requirements and rigid phase completion. Waterfall is not wrong. Using it when requirements are unstable is. Question 20. A health system commissions a new chronic care platform whose user requirements are still being discovered as patients and clinicians interact with early prototypes. The development team plans to refine scope, designs, and deliverables iteratively as the project unfolds. Which SDLC approach best fits the situation? Your options are A. Waterfall with rigid sequential phases. B. Predictive, assuming the project can be planned end to end. C. Closed with no environmental input. D. Adaptive, with iterations that respond to changing needs as the project progresses. Don't overthink it. Which one feels right? The correct answer is D. Adaptive, with iterations that respond to changing needs as the project progresses. D is correct because an adaptive SDLC approach assumes the project must be flexible and adjust to changing needs as it progresses. Iterations let parts of the system reach users early so that feedback can shape later cycles, which fits a project where requirements are still emerging. A is wrong because waterfall is rigid and sequential with no return to earlier phases. It is the opposite of what a discovery-heavy project needs. B is wrong because a predictive approach assumes the project can be planned and organized end to end. The scenario explicitly describes evolving requirements that cannot be fully planned. C is wrong because closed is a systems theory term about boundary permeability, not an SDLC approach. It does not describe a development method. The adaptive approach to the system development lifecycle is built on a simple premise. You cannot fully know what a system needs to do until you start building and using it. Flexibility is structural here, not a sign of poor planning. Each cycle produces working software that real users can react to. Their feedback directly shapes the next cycle. Requirements emerge, designs adjust, and the team moves forward in manageable steps, keeping the cost of changing direction low. Predictive approaches like waterfall lock in requirements at the start and flow in one direction. Adaptive approaches replace that single path with repeating cycles. So discovery and change are built into the structure rather than treated as failures. The exam trap is reading adaptive as sloppy or unplanned. The discipline is real, it just focuses on cadence and feedback rather than locking in a complete plan that will later prove wrong. When a question stem mentions iterations, evolve in requirements, or feedback driving design, the name concept is the adaptive approach. Watch for waterfall or predictive planning as distractors. Those assume a stability that adaptive work deliberately rejects. Question 24. A development team plans an oncology nursing module by completing fully working portions of the system in small chunks, integrating each chunk with the larger application as it finishes, and shipping pieces to clinicians for evaluation along the way. Which SDLC approach best describes this method? Your options are A. Waterfall development, completing all design before any coding. B. Incremental development, completing portions in small increments that are integrated as completed. C. Predictive planning with no scope changes after analysis. D. Hierarchical development mapped onto reporting structures. Got a guess? Lock it in. The correct answer is B. Incremental development, completing portions in small increments that are integrated as completed. B is correct because incremental development is the SDLC approach that completes portions of the system in small increments across iterations, with each increment integrated into the whole as it is finished. The advantage is that working portions reach users earlier than they would in a strict waterfall. Is wrong because waterfall completes all design before coding and does not deliver working portions early. The scenario describes ongoing delivery, not deferred delivery. C is wrong because predictive planning assumes the entire scope is settled before development. The scenario allows for clinician feedback to shape later increments, which is adaptive in spirit. D is wrong because hierarchical development is not a recognized SDLC approach. The term refers to organizational reporting structures, not software lifecycle method. Incremental development is an approach where a system is built and delivered in small, functional pieces rather than all at once. Each completed piece integrates immediately into the broader application, keeping the system continuously growing. The defining feature is that integration never waits. Every completed increment, with its code, test, and documentation, joins the rest of the system immediately, keeping the integration burden small and problems discoverable at a manageable scale. Contrast this with monolithic development, where the entire system is built before any of it reaches users. By the time integration testing begins in a monolithic build, fixing fundamental problems is prohibitively expensive because every component depends on every other. A critical exam distinction: incremental means delivering working pieces in chunks, while iterative means repeating cycles of refinement. A project can be both, but the terms are not interchangeable. Incremental specifically emphasizes integrated, working software delivered to users before the whole system is complete. On exam day, look for phrases like small portions, integrated as completed, and ongoing delivery. When a STEM describes functionality reaching users before the full system exists, incremental development is the named approach, not waterfall, not purely predictive planning. Question 25. A team building a community health portal decides to first construct a thin end-to-end version of the application that supports user login, a single dashboard view, and a single appointment request, with the understanding that future iterations will flesh out richer functionality. Which SDLC technique does this represent? Your options are A. Walk-in skeleton, in which a complete end-to-end system is built with bare-bones functionality first. B. Big Bang Go Live, in which all modules launch simultaneously. C. Refactoring, in which existing code is restructured for higher quality. D. Pair programming, in which two developers share one workstation. Which one is it? Pause the video if you need more time. The correct answer is A. Walk-in skeleton, in which a complete end-to-end system is built with bare-bones functionality first. Is correct because a walking skeleton is a development approach in which the complete front-to-back structure of the system is built early with only bare-bones functionality, then later iterations add features and depth. A thin end-to-end portal with login and a single workflow is a textbook example. B is wrong because A, Big Bang Go Live, refers to launching all modules at once during deployment, not to a development structure where minimal end-to-end functionality is built first. C is wrong because refactoring restructures existing code to improve quality without changing external behavior. It is not the technique used to scaffold a new system. D is wrong because pair programming is an XP practice where two developers collaborate at one workstation. It is unrelated to the architectural choice of a thin end-to-end build. A walking skeleton is a development strategy where the full end-to-end structure of a system is built first, but with only the bare minimum functionality. Think of it as erecting the entire frame of a building before furnishing any room. Every major layer, database, application logic, user interface, and deployment pipeline, is constructed simultaneously from day one. Each layer does only the absolute minimum needed to support the system's most basic workflow, end to end. The critical distinction is that a walking skeleton is not a prototype. A prototype is often disposable, built to demonstrate, then discarded. A walk-in skeleton is real, production-grade infrastructure on which every future feature is built. Nothing gets replaced, depth is simply added on top. The metaphor is intentional. The skeleton stands, connects and moves before any feature work goes deep. Integration problems surface immediately rather than emerging late in the project when they are far more costly to fix. On exam day, watch for phrases like thin end-to-end version, working system early, and depth added in later iterations. When those appear, walking skeleton is the named approach. Nzam kayasa, distinct from incremental development and from throwaway prototypes. Question 26. A team revising its development charter highlights 4 values, namely valuing individuals and interactions over processes and tools, working software over comprehensive documentation, customer collaboration over contract negotiation, and responding to change over following a plan. Which philosophy do these statements come from? Your options are A. Six Sigma quality philosophy, B. The waterfall model philosophy, C. Agile development philosophy, D. The Cynefin framework. Take a second. Which answer would you pick? The correct answer is C. Agile development philosophy. C is correct because these 4 value statements are the core values of the Agile development philosophy. They emphasize people, working software, collaboration, and adaptability over rigid processes, documentation, contracts, and plans. A is wrong because Six Sigma is a quality improvement methodology focused on reducing defects and variation. Its core principles are not these 4 value statements. B is wrong because the waterfall model emphasizes thorough planning and sequential execution, which is closer to the opposite of the 4 Agile values. D is wrong because the Cynefin framework is a sense-making model that classifies situations into domains. It is not a software development value system. The Agile Manifesto emerged in the early 2000s when software practitioners formalized the values shared by high-performing teams. Rather than inventing new ideas, it gave the industry a common vocabulary for what already worked. These 4 values have shaped how software teams operate for more than 2 decades. Each value is stated as a trade-off. The thing on the left is prioritized over the thing on the right. Agile doesn't dismiss processes, documentation, contracts, or plans. It simply reorders what counts as evidence of success and guides decisions when the 2 sides come into tension. Notice that every value names both sides explicitly. The right-hand items still have value. Agile teams plan, document, and use contracts. The manifesto is making a prioritization statement, not a dismissal. When circumstances force a choice, the left side wins. This is what separates Agile most sharply from predictive approaches like waterfall. A waterfall project treats plan adherence as a virtue even when the plan no longer fits reality. Agile teams plan extensively but adjust when circumstances change. The plan serves the goal, not the other way around. When an exam stem lists these 4 trade-offs together, the answer is the Agile Manifesto. Watch for distractors like Six Sigma, which addresses quality, or waterfall, which largely opposes these values. Recognizing the paired structure is your fastest path to the right answer. Question 27. A team adopting the unified process is in the first phase of a new health information system project. They are developing a rough version of the system, defining initial scope, building the business case, and producing rough cost and schedule estimates. Which unified process phase are they in? Your options are A. Elaboration, in which the vision is finalized and the core architecture is built. B. Inception, in which scope and the business case are roughly defined. C. Construction, in which lower risk elements are iteratively built. D. Transition, in which beta testing and final deployment occur. Before I reveal it, which one do you think is right? The correct answer is B. Inception, in which scope and the business case are roughly defined. B is correct because inception is the first phase of the unified process, focused on developing a rough version of the system, defining initial scope, building the business case, and producing rough cost and schedule estimates. The scenario describes exactly this work. A is wrong because elaboration is the second UP phase, where the vision is finalized, requirements are described, and the core architecture is built. The team has not progressed that far. C is wrong because construction is the third UP phase, when lower risk elements are iteratively built. The team has not even fully scoped the work yet. D is wrong because transition is the final UP phase, focused on beta testing and deployment. The team is at the beginning, not preparing to ship. The unified process is an object-oriented development methodology that uses the unified modeling language and organizes work into 4 sequential phases, each of which can include multiple internal iterations. The 4 phases proceed in order: inception, elaboration, construction, and transition. The structure is sequential across phases but iterative within each one, giving projects both rhythm and flexibility. Inception is not just a kickoff meeting. It produces real artifacts, a vision document, a preliminary use case model, an initial risk list, and cost and schedule estimates that honestly reflect early uncertainty. Within Inception, the team sketches requirements, identifies major risks, drafts high-level architecture, and decides whether the project is worth pursuing, all before any production quality code or final designs are created. When an exam STEM describes a team developing a rough system version, building the business case, defining scope, and producing rough estimates, those are the signature deliverables of the inception phase, not elaboration or any later phase. Question 28. A development team practicing extreme programming places two developers at the same workstation, where one writes code and the other reviews each line in real time, and the pair switches roles regularly. Which extreme programming practice is this? Your options are A. Refactoring, the restructuring of code for higher quality. B. Continuous integration, the frequent merging of code into a shared branch. C. Collective code ownership, the practice of allowing anyone to modify any code. D. Pair programming, in which two developers design, code, and test together at one workstation. What's your answer? Commit to one before I continue. The correct answer is D. Pair programming, in which two developers design, code, and test together at one workstation. D is correct because pair programming is the extreme programming practice in which two developers work together on designing, coding, and testing software at one workstation. Real-time review and role switching are the hallmark of this practice. A is wrong because refactoring revises and restructures existing code to improve quality, often without changing behavior. It is a separate practice from pair programming. B is wrong because continuous integration is the practice of frequently merging code into a shared branch and verifying it. It does not describe two developers sharing a workstation. C is wrong because collective code ownership is the policy that anyone on the team can modify any part of the code. It is a governance practice, not the activity at the workstation. Extreme programming, or XP, is an agile methodology that takes software best practices and pushes them to their limits. One of its most distinctive techniques is pair programming, where two developers share a single workstation to write and review code simultaneously. The driver focuses on writing syntax and structure in the moment. The navigator holds the broader view, watching for design flaws, edge cases, and how the code fits the larger system. They swap roles regularly so both developers stay engaged and familiar with every line. Traditional review happens after the fact when context has cooled and changes are expensive. Pair programming moves review to the exact moment of creation, so problems are caught when fixing them is still cheap. Pair programming looks inefficient when measured by lines of code per developer hour, measured by defect rates, onboarding speed, and maintainability. Well-executed pair programming consistently outperforms solo development with delayed review. On exam day, when the STEM describes two developers at one workstation switching roles and reviewing code in real time, that is pair programming. XP's answer to the high cost of finding defects too late. Question 29. A nursing informatics team improving an outdated reporting module rewrites internal data structures, simplifies tangled functions, and clarifies naming conventions while preserving every existing report exactly as users see it. Which extreme programming practice does this work represent? Your options are refactoring, the revising and reorganizing of existing code to higher quality without changing external behavior. B. Pair programming, in which two developers share a workstation. C. On-site customer embedding a user with the development team. D. Small releases, frequently shipping small increments to users. Pick one. Trust your gut. Here's your chance to test yourself. The correct answer is A. Refactoring, the revising and reorganizing of existing code to higher quality without changing external behavior. A is correct because refactoring is the XP practice of revising, reorganizing, and rebuilding parts of a system to make it higher quality, while preserving the external behavior users experience. Restructuring internal code while keeping reports unchanged is a textbook example. B is wrong because pair programming describes the staffing model at the workstation, not the activity of restructuring existing code. C is wrong because on-site customer embeds a user with the development team to give continuous feedback. The scenario is about code quality work, not customer presence. D is wrong because small releases is about shipping small increments to users. The scenario does not describe release cadence, only internal code restructuring. Refactoring is the disciplined practice of restructuring existing code to improve its quality without changing what it does for users. It was popularized by Martin Fowler and became a cornerstone of Agile and extreme programming. As software evolves, features pile up in ways the original architecture never anticipated. This structural decay makes the code base harder to reason about and harder to change. Refactoring is the ongoing maintenance that keeps it in check. The key distinction is that refactoring changes existing code incrementally while preserving behavior at every step. Rewriting starts from scratch and carries far greater risk because the system doesn't work again until the new version is complete. Each refactoring move is intentionally small. Split a bloated function. Rename a confusing variable. Extract duplicated logic into a shared utility. Small steps are easy to verify and easy to roll back if something goes wrong. When an exam stem describes revising and reorganizing existing code while preserving external behavior, the answer is refactoring. Distractors like pair programming, on-site customer, and small releases describe entirely different practices. Question 30. A development team using Scrum commits to a defined goal that they will complete in a shorter, time-bounded mini-project during which the team is protected from outside distractions and the product backlog is held stable. What does Scrum call this time-bounded mini-project? Your options are an iteration plan, B, a release window, C, a sprint, D, a swim lane. Which would you go with? Lock it in before the reveal. The correct answer is C, a sprint. C is correct because a sprint is the basic Scrum work process, defined as a time-controlled mini-project that implements a specific portion of the system. During a sprint, the team commits to a goal and is protected from changes until the sprint ends. A is wrong because iteration plan is a generic term used in many adaptive methodologies. Scrum specifically calls its time-bounded mini-project a sprint. B is wrong because release window is a deployment concept describing when releases occur. It is not the Scrum work cycle. D is wrong because a swim lane is a workflow analysis technique used to depict who does which steps. It is not a Scrum work cycle. Scrum is an agile methodology built around short, intense bursts of focused work. Understanding how its core structures fit together helps you recognize it on the exam and in practice. Scrum relies on 3 interlocking pieces. The product owner decides what matters most. The Scrum Master keeps the team on track and shields them from outside interference. The product backlog is the living, prioritized list of everything that needs to be built. Each sprint begins with planning drawn from the backlog, runs for 1 to 4 weeks with daily stand-ups keeping the team aligned, and closes with a review where real, working software is demonstrated to stakeholders. A retrospective then shapes how the team improves for the next cycle. 3 disciplines define a true sprint. The time box ends on its planned date regardless of completion. The scope is locked once the goal is committed, so mid-sprint changes are deferred. And the team must produce demonstrable, usable software at the end, not just progress. When a question stem mentions a time-controlled mini-project, a defined sprint goal, or protection from outside distraction, you are looking at a sprint. Short cycles alone are not enough. It is the combination of fixed time, protected scope, and working software that defines Scrum. Question 31. A new project manager preparing for the PMI's Project Management Professional exam reviews the framework of knowledge areas defined in the project management body of knowledge. Approximately how many knowledge areas does the PMBOK identify? Your options are A. 3 knowledge areas, B. 10 knowledge areas, C. 15 knowledge areas, D. 21 knowledge areas. Don't overthink it. Which one feels right? The correct answer is B. 10 knowledge areas. B is correct because the project management body of knowledge, abbreviated PMBOK, identifies 10 knowledge areas, including project integration, scope, time, cost, quality, human resources, communications, risk, procurement, and stakeholder management. 10 is the correct count. A is wrong because 3 is far too few and does not match any standard PMBOK structure. C is wrong because 15 overstates the count. The PMBOK does not enumerate that many knowledge areas. D is wrong because 21 is the count of care components in the clinical care classification system, not PMBOK knowledge areas. The project management body of knowledge, PMBOK, is the foundational framework developed by the Project Management Institute. It organizes all of project management into 10 distinct knowledge areas that together map everything a project manager must think about. Integration management sits at the center, developing the project charter and weaving all other areas together. Surrounding it are the 9 domains, from scope and time to risk and procurement, each covering its own processes, tools, and techniques. The framework's power comes from integration. Perfect scope management cannot save a project that ignores stakeholders. Rigorous cost control cannot save one that ignores quality. Every area demands appropriate attention, and the vocabulary travels across healthcare, construction, and software alike. Memorizing the count of 10 is the starting point, not the finish line. The real competence is understanding what each area contributes and recognizing that neglecting even one can derail an otherwise well-run project. Question 32. A nursing informatics project manager is wrapping up an inpatient documentation system project. The system is delivered, the operations team has accepted handoff, and the project manager is finalizing release notes, lessons learned documentation, and stakeholder communications. Which project phase activities does this work represent? Your options are A. Initiation activities, B. Planning activities, C. Execution activities, D. Closure activities, including release management, project delivery, lessons learned, and handoff. Got a guess? Lock it in. The correct answer is D. Closure activities, including release management, project delivery, lessons learned, and handoff. D is correct because closure activities include release management, formal project delivery, documentation of lessons learned, and formal handoff to operational and maintenance teams. The work described aligns precisely with this phase. A is wrong because initiation activities involve submitting the project proposal and securing approval. The project is being closed, not started. B is wrong because planning activities involve creating detailed plans for execution. The project has already been executed and delivered. C is wrong because execution activities involve building deliverables and customer testing. The project has moved past that phase to wrap up. Closure is the final phase of project management and the one most often skipped. But ending a project properly is what turns completion into lasting organizational value. Closure has 4 deliverables: release management, formal project delivery, lessons learned, and handoff to operations. Each one closes a gap that could otherwise haunt the team that inherits the system. Closure sits between the project team and the operations team. Its job is to make that handoff clean. So the operations team inherits a system they understand, along with the documentation to support it. Closure depends on both documentation and ceremony. Documentation captures decisions, lessons, and support procedures. Ceremony, like a formal acceptance sign-off, marks the definitive end. Neither works well without the other. When an exam stem mentions release management, project delivery, lessons learned, or formal handoff to operations together, the name phase is closure, not maintenance, not execution. Closure is what makes the ending real. Question 33. A finance committee evaluating two proposed nursing informatics initiatives wants a single number that converts each project's expected dollar benefits and dollar cost over time into a present-day comparison. Which financial measure best fits this need? Your options are A. Net present value, which converts future dollar benefits and cost of an investment into present terms. B. Tangible benefit, which is any benefit that can be measured in dollars. C. Intangible benefit, which is a benefit that accrues but cannot be measured quantitatively. D. Critical path, which identifies tasks that determine project duration. Which one is it? Pause the video if you need more time. The correct answer is A. Net present value, which converts future dollar benefits and costs of an investment into present terms. A is correct because net present value, abbreviated NPV, is the present value of dollar benefits minus the present value of dollar costs of a particular investment, expressed as a single number that allows direct comparison across projects with different timelines. B is wrong because a tangible benefit is one that can be measured in dollars, which is a building block of cost-benefit analysis, but not a single comparison number across projects. C is wrong because an intangible benefit cannot be measured quantitatively at all, so it cannot serve as the comparison number the committee wants. D is wrong because critical path identifies the sequence of tasks that determines project duration. It is a scheduling concept, not a financial comparison measure. Net present value is the financial tool that converts all future costs and benefits of an investment into today's dollars and reports the difference as a single number. It exists because money has a time value. $1 today is worth more than $1 5 years from now. The mechanism works in 3 steps. Each future cash flow is reduced, discounted, by a rate that reflects time and risk. The further out a cash flow occurs, the more it shrinks. Once all flows are converted to present-day equivalents, you sum them and subtract costs from benefits. Each future cash flow is pulled back to the present and discounted more the further away it is. The sum of all those present-day values minus initial costs is the net present value. A common exam trap is confusing NPV with break-even point and payback period. Break-even is the moment cumulative benefits equal cumulative costs. Payback period is how long that takes. Only NPV accounts for every cash flow across the investment's lifetime and adjusts each one for time value. When an exam stem mentions a single number for comparing investments, present-day terms, or discounted future cash flows, the answer is net present value. It is the tool that gives investment decisions an analytic foundation across different timelines. Question 34. A program manager wants a chart that visually portrays project task durations using horizontal bars superimposed on a calendar, making it easy to see what is happening when. Which project management chart best fits this description? Your options are A. Peer T chart, which shows task interrelationships in a network diagram. B. Swim lane diagram, which shows who performs which steps of work. C. Gantt chart, which shows task duration as horizontal bars on a calendar. D. Process map, which shows a workflow's value added and non-value added steps. Take a second. Which answer would you pick? The correct answer is C. Gantt chart, which shows task duration as horizontal bars on a calendar. C is correct because a Gantt chart is a graphical view of the duration of tasks and activities shown as a progression on a timeline, using horizontal bars superimposed on a calendar. Visual scheduling on a calendar with bars is its defining feature. A is wrong because a PERT chart organizes tasks and their interrelationships in a network diagram, which is useful for sequencing but does not portray duration visually on a calendar. B is wrong because a swim lane diagram shows which functional groups or roles perform which steps. It is a workflow analysis tool, not a calendar-based schedule view. D is wrong because a process map depicts the steps of a workflow and helps identify value-added versus non-value-added activities. It is not a calendar-based schedule view. A Gantt chart turns a project schedule into a picture. Instead of dense tables of dates, you get horizontal bars stretched across a calendar, making it immediately clear what is happening when. Each bar's position tells you when a task starts and ends. Its length shows planned duration. Arrows capture dependencies between tasks, and a diamond shapes mark milestones. Zero duration events that signal key checkpoints. The power of Gantt charts comes from visual encoding. Bar length encodes how long a task takes. Horizontal position encodes when it happens. And stacking bars vertically reveals tasks running in parallel, all readable at a single glance. The classic exam trap is confusing Gantt with PERT. A Gantt chart shows the schedule on a calendar timeline. A PERT chart maps task dependencies in a network. Mature project managers use both, but for entirely different purposes. When you see the words horizontal bars, calendar timeline, task duration, or visual schedule in an exam STEM, the answer is Gantt chart. Remember, Gantt communicates the schedule, PERT analyzes the path. Question 35. An EHR upgrade project initially scoped to update 3 modules quietly grows over several months as stakeholders successfully request additional features, integrations, and reports. The original budget and timeline are now badly exceeded. Which project management phenomenon best names this pattern? Your options are A. Critical path expansion, B. Scope creep, the gradual increase of the original project scope, C. Refactoring, the restructuring of existing functionality, D. Reverberation, the unintended consequences of a system change. Before I reveal it, which one do you think is right? The correct answer is B. Scope creep, the gradual increase of the original project scope. B is correct because scope creep is the gradual increase of the original scope of a project during execution, frequently necessitating additional time, cost, and resources. Quiet accumulation of feature requests that overrun budget and schedule is its textbook signature. A is wrong because critical path expansion is not a standard project management term. The phenomenon described is uncontrolled scope growth, not a redefinition of the critical path. C is wrong because refactoring is a software development practice for restructuring existing code. It does not describe project scope expansion. D is wrong because reverberation refers to ripple effects of a system change, not to gradual scope growth on a project. Scope creep is one of the most common and most destructive patterns in project management. It describes the gradual expansion of a project's original scope during execution, and understanding why it happens is just as important as knowing what to call it. Projects rarely fail in a single dramatic moment. They fail through accumulation, one modest feature request, one workflow expansion, one late stakeholder requirement, each harmless alone, but overwhelming together. The core mechanism is incremental commitment without incremental adjustment. Every addition to scope should trigger an explicit conversation about whether the budget, timeline, and resources also need to change. When that conversation doesn't happen, scope grows, but resources stay fixed. Scope creep is not just a failure to say no. It is a structural problem requiring structural solutions. Change control processes, explicit baselines, and formal approval gates give project managers the tools to handle new requirements deliberately rather than reactively. On exam day, watch for phrases like gradual increase of original scope or budget overruns from accumulated changes. The middle path is never refusing all additions or accepting all of them. It is explicit change control with matching adjustments to scope, schedule, and resources. Question 36. An informatics team needs a controlled clinical terminology that is comprehensive enough to encode diseases, clinical findings, etiologies, procedures, and outcomes at the point of care, and that is widely recognized as an international standard for clinical content. Which terminology best fits this need? Your options are A. SNOMED CT, the most comprehensive clinical terminology and an international standard for healthcare data. B. ICD-10 PCS, designed primarily for procedural coding and reimbursement reporting. C. CPT, designed primarily for outpatient procedure billing. D. RxNorm, a normalized drug naming system. What's your answer? Commit to one before I continue. The correct answer is A. SNOMED CT, the most comprehensive clinical terminology and an international standard for healthcare data. A is correct because SNOMED CT is the most comprehensive clinical terminology and is recognized internationally as a standard for healthcare data. It encodes diseases, clinical findings, etiologies, procedures, and outcomes at a level of granularity designed for point-of-care use. B is wrong because ICD-10 PCS is a procedural coding classification used primarily for output reporting, public health surveillance, and reimbursement. It is not designed for granular point-of-care clinical content. C is wrong because CPT is the current procedural terminology used for outpatient procedure billing. It is narrow in scope and not a comprehensive clinical terminology. D is wrong because RxNorm is a normalized drug naming system covering drug names, ingredients, strengths, and doses. It does not cover diseases, findings, or procedures broadly. SNOMED CT is the most comprehensive clinical terminology in use today and has become an international standard for representing healthcare data. It encodes diseases, findings, procedures, etiologies, and outcomes at a level of granularity suited for direct point-of-care use. The terminology is built from concepts, descriptions, and the relationships among them. Those relationships are formal enough that software can reason across them, surfacing relevant concepts even when they are not directly named in a query, making SNOMED CT a model of clinical knowledge, not just a vocabulary. The classic exam trap is confusing SNOMED CT with ICD. SNOMED CT is designed for input, capturing rich clinical detail inside the EHR where clinicians never see the codes. ICD is designed for output, aggregating that detail into reportable categories for billing and statistics. The two systems complement each other. When an exam stem mentions comprehensive clinical terminology, international standard, granular clinical content, or point-of-care documentation, SNOMED CT is the answer. Distractors like ICD-10, CPT, and RxNorm each serve narrower, distinct purposes and should not be confused with SNOMED CT's broad clinical scope. Question 37. A revenue cycle director needs a coding system to assign diagnoses on inpatient claims for reimbursement and to support administrative reporting and public health surveillance. Which classification system best fits this purpose? Your options are A. SNOMED CT, designed for granular clinical documentation. B. Lewin, designed for laboratory and clinical observations. C. NANDA, designed for nursing diagnoses. D. ICD-10-CM, an output system designed for diagnostic coding, public health surveillance, and reimbursement. Pick one. Trust your gut. Here's your chance to test yourself. The correct answer is D. ICD-10-CM, an output system designed for diagnostic coding, public health surveillance, and reimbursement. D is correct because ICD-10-CM is a clinical modification of the International Classification of Diseases, designed as an output system for general reporting purposes, public health surveillance, administrative performance monitoring, and reimbursement of healthcare services. A is wrong because SNOMED CT is designed for clinical documentation at the point of care. It is more granular than what reimbursement claims use as primary diagnostic coding. B is wrong because Lewin is the standard for laboratory and clinical observations, not for diagnostic claims coding. C is wrong because NANDA is a standardized terminology for nursing diagnoses, not a billing classification used for medical reimbursement claims. ICD-10 is the world's dominant standard for diagnostic coding, used for billing, public health surveillance, and administrative reporting. Understanding how it works and when to use it is essential vocabulary for nursing informatics. In the US, ICD-10 appears in two forms. ICD-10-CM codes diagnoses, while ICD-10-PCS codes inpatient procedures. Together they offer roughly 68,000 codes, far more than the predecessor ICD-9, enabling highly specific reporting. ICD-10 uses a hierarchical classification. Conditions are grouped into chapters by body system, then broken into categories and subcategories that grow progressively more specific. Each final code pinpoints a position in that hierarchy precise enough for billing and reporting. The classic exam trap is confusing ICD-10 with SNOMED CT. ICD is an output system built for billing and surveillance. Codes are assigned after the encounter. SNOMED CT is an input system built for point-of-care clinical documentation. They are not interchangeable. When an exam stem mentions diagnostic claims coding, reimbursement, or public health surveillance, ICD-10 is the answer. Distractors like SNOMED CT, Lewin, and NANDA each serve distinct purposes that do not match the billing and reporting use case. Question 38. An interface analyst is mapping incoming laboratory results from an outside reference lab into the hospital EHR. To exchange these observations consistently across systems, the team selects a standard whose codes use 6 axes, including the name of the observation, property, timing, sample type, scale, and method. Which standard is this? Your options are A. ICD-10-CM, a diagnostic classification. B. RxNorm, a drug naming standard. C. Lewin, the standard coding system for laboratory and clinical observations. D. NIC, the nursing interventions classification. Which would you go with? Lock it in before the reveal. The correct answer is C. Lewin, the standard coding system for laboratory and clinical observations. C is correct because Lewin, the logical observation identifiers names and codes standard, is the widely adopted standardized coding system for laboratory and clinical observations. Each Lewin name uses 6 axes, namely the name of the observation, property, timing, sample type, scale, and method. A is wrong because ICD-10-CM is a diagnostic classification system, not an observation coding system. It does not use the 6-axis structure. B is wrong because RxNorm normalizes drug names. It does not encode laboratory observations. D is wrong because NIC, the nursing interventions classification, encodes nursing interventions. It is not a lab observation standard. LONC, Logical Observation Identifiers Names and Codes, is the standard coding system for laboratory and clinical observations. It gives every distinct observation a unique code so that systems across different organizations can exchange results with shared meaning. Each LONC code is constructed from 6 axes: the name of the observation, the property measured, the timing, the sample type, the scale, and the method. Changing any single axis produces a different LONC code, which is how the system achieves precise, unambiguous identification. Before LONC, every interface between a lab and an EHR required custom code-to-code mapping, and that burden multiplied with every new connection. With LONC, each system maps its local codes to the standard once, and any other LONC-enabled system can consume the data without further translation. A common exam trap is confusing LONC with other standards. ICD-10-CM codes diagnoses, RX norm codes medications, and NIC codes nursing interventions. When a question mentions laboratory results, vital signs, or clinical observations crossing system boundaries, LONC is the answer. Remember LONC's 6-axis structure: name, property, timing, sample, scale, and method makes it precise enough to support unambiguous exchange of clinical observation across any organization or application. Question 39. A nurse educator describes 3 companion standardized nursing terminologies to a class. The first encodes nursing diagnoses, the second encodes nursing interventions, and the third encodes nursing outcomes. Which combination correctly identifies the 3? Your options are A. ICNPC and Omaha system, B. NANDA, NIS, and NOS, C. PNDS, LONC, and SNOMED, CT, D. RX norm, CPT, and ICD-10. Don't overthink it. Which one feels right? The correct answer is B. NANDA, NIC, and NOC. B is correct because NANDA International encodes nursing diagnoses. The Nursing Interventions Classification, or NAC, encodes interventions, and the Nursing Outcomes Classification, or NOC, encodes outcomes. Together they form a widely used trio for the nursing process. A is wrong because ICNP, CCC, and Omaha system are each standalone nursing terminologies that span diagnoses, interventions, and outcomes individually. They do not split the nursing process across 3 companion sets the way NANDA, NICS, and NOC do. C is wrong because PNDS is the perioperative nursing dataset. LONC and SNOMED CT are multidisciplinary, not nursing specific. The combination does not match the diagnoses, interventions, outcomes split. D is wrong because RX norm, CPT, and ICD-10 are drug procedural and diagnostic coding standards. None of them encode nursing diagnoses or interventions. Nursing as a discipline needed a shared vocabulary that mirrors the structure of the nursing process itself. NANDA, NIC, and NOC are 3 companion terminologies designed to work together, each covering a distinct phase of that process. NANDA encodes the clinical judgments nurses make about patient problems. NIC catalogues the treatments and activities nurses perform in response. NOC defines measurable patient and caregiver outcomes evaluated on a standardized scale. The 3 terminologies mirror clinical reasoning. A nurse identifies a NANDA diagnosis, selects a relevant NIC intervention, then evaluates progress against a NOC outcome scale. Each terminology is maintained separately, but is designed to interlock with the others. This is the key exam distinction. Systems like the Omaha system or ICNP encode diagnoses, interventions, and outcomes within a single standalone terminology. NANDA, NIC, and NOC split those elements across 3 separately maintained but companion sets. When an exam stem mentions 3 companion terminologies covering nursing diagnoses, interventions, and outcomes encoded separately, Nanda, Nisi, and NOC is the answer. Their defining feature is that they work together while remaining distinct. Question 4. A home health agency wants a standardized classification developed for documentation across the continuum of care, especially in home care, public health, and community settings. The terminology includes a problem classification scheme, an intervention scheme, and a problem rating scale for outcomes. Which terminology best fits these requirements? Your options are A. The Omaha system, designed for home care, public health, and community settings. B. The perioperative nursing data set. C. NANDA International. D. The nursing management minimum data set. Got a guess? Lock it in! The correct answer is A. The Omaha system, designed for home care, public health, and community settings. A is correct because the Omaha system is a standardized classification designed to document client care from admission to discharge across the continuum, with primary application in home care, public health, and community settings. Its 3 schemes are the problem classification scheme, the intervention scheme, and the problem rating scale for outcomes. B is wrong because the perioperative nursing data set is designed specifically for perioperative care, not for home or community settings. C is wrong because NANDA International encodes nursing diagnoses across all nursing settings, but does not have the 3 scheme structure or community focus the question describes. D is wrong because the nursing management minimum data set focuses on nursing administrative data for management decision making, not on direct care documentation in community settings. The Omaha system is one of the oldest standardized nursing terminologies, developed in the 1970s specifically for home health, public health, and community-based care. Its public domain status means organizations can adopt it without licensing fees, making it especially practical for agencies with limited resources. The system is built from 3 interlocking schemes. The problem classification scheme identifies patient health concerns, the intervention scheme organizes assessments and care actions, and the problem rating scale for outcomes tracks progress over time. Together, they capture the full arc of community-based care. In practice, a nurse identifies a problem, selects relevant interventions, and tracks outcomes, all using standardized vocabulary. This makes documentation comparable across nurses, visits, and organizations sharing the same system. Standardized nursing terminologies are not interchangeable. Each was designed for a specific context. The Omaha system fits community care, while the perioperative nursing data set fits surgical settings, and NANDA International with Annexa NOC fits inpatient nursing process documentation. When an exam stem mentions home care, public health, community settings, or any of the 3 Omaha schemes by name, the Omaha system is your answer. Recognizing those signal phrases is the key to avoiding distractors on test day. Question 41. A hospital is preparing to launch a system that allows physicians to enter medication, lab, and imaging orders directly into the EHR rather than writing them on paper or telephoning them to the unit. The project team is paying close attention to workflow effects and unintended consequences. Which capability is being deployed? Your options are A. Barcode medication administration, which validates the right drug at the bedside. B. Clinical document architecture, which structures clinical documents for exchange. C. Computerized provider order entry, also known as CPOE, in which providers enter orders directly into the system. D. Health information exchange, which moves data between organizations. Which one is it? Pause the video if you need more time. The correct answer is C. Computerized provider order entry, also known as CPOE, in which providers enter orders directly into the system. C is correct because computerized provider order entry, abbreviated CPOE, is the capability that lets providers enter medication, lab, and imaging orders directly into the EHR. It carries well-known workflow implications, often called the unintended consequences of CPOE. A is wrong because barcode medication administration is a separate capability that validates the right patient and drug at the bedside. It does not address provider order entry. B is wrong because clinical document architecture is a structural standard for health document exchange, not the order entry capability itself. D is wrong because health information exchange refers to moving data between organizations. It is not the order entry workflow being deployed. Computerized provider order entry. CPOE is the EHR capability that lets clinicians enter medication, lab, and imaging orders directly into a structured digital form. It replaced handwritten and verbal orders, which were major sources of preventable harm. Handwritten and verbal orders failed in predictable ways: illegible writing, transcription mistakes, incomplete information, and communication delays all contributed to errors that structured digital entry was designed to eliminate. CPOE works by addressing each old failure mode directly. Structured forms eliminate ambiguity, required fields prevent omissions, and immediate electronic transmission replaces the slow handoff chain that delayed care. But CPOE is not automatically beneficial. Poor implementation brings its own risks: disrupted workflows, alert fatigue from aggressive decision support, new data entry errors from bad interface design, and communication breakdowns when informal paper-based cues disappear. The key exam principle is that CPOE's value depends entirely on implementation quality, workflow analysis, careful alert tuning, and ongoing monitoring of unintended consequences are what separates CPOE that improves care from CPOE that frustrates clinicians and introduces new safety issues. Question 42. A medical surgical unit deploys a workflow in which a nurse scans a patient's wristband and the medication's barcode at the bedside before administration, prompting the system to verify the right patient, drug, dose, route, and time. Which closed-loop safety capability is being used? Your options are A. Computerized provider order entry, B. Barcode medication administration, also called BCMA, which validates medications at the bedside, C. Health information exchange, D. Tallman lettering on lookalike drug names. Take a second. Which answer would you pick? The correct answer is B. Barcode medication administration, also called BCMA, which validates medications at the bedside. B is correct because barcode medication administration, abbreviated BCMA, is the bedside scanning workflow that validates the right patient, drug, dose, route, and time before administration. Closed-loop bedside scanning is its defining feature. A is wrong because computerized provider order entry is the order entry capability used by providers, not the bedside administration check. C is wrong because health information exchange moves data between organizations. It does not validate medication administration at the bedside. D is wrong because Tallman lettering is a typographic technique that helps clinicians distinguish lookalike medication names. It does not perform bedside verification. Barcode medication administration, or BCMA, is the electronic safety layer that stands between a medication and the patient who receives it. It works by scanning two barcodes at the bedside, the patient's wristband and the medication itself. Traditionally, nurses relied on memory and discipline to verify the 5 rights: right patient, drug, dose, route, and time. BCMA converts that human check into an electronic one, comparing scanned codes against the active order in real time. The closed loop works like this. The nurse scans the wristband, then the medication, and the system instantly checks both against the patient's active orders. A match allows administration to proceed. A mismatch triggers an alert before any harm can occur. BCMA is especially effective at catching wrong patient and wrong drug errors, including medications that were mispicked or mislabeled earlier in the process. These errors would be invisible to a manual check but are caught the moment the barcodes do not match. BCMA is not foolproof. Damaged barcodes, missing wristbands, and time pressure all drive workarounds, some of which completely defeat the safety purpose. Informatics teams must monitor actual scanning compliance, not just whether the system is deployed. Question 43. A nursing informaticist is reviewing the historical stages of the Meaningful Use program. Which goal best matches stage 1 of meaningful use as originally defined by the EHR incentive program? Your options are A. Improving outcomes through advanced thresholds. B. Promoting data interoperability with higher objective thresholds. C. Advanced clinical processes and patient portal capabilities. D. Capturing patient data and sharing it with clinicians and patients. Before I reveal it, which one do you think is right? The correct answer is D. Capturing patient data and sharing it with clinicians and patients. D is correct because stage 1 of meaningful use focused on data capture and sharing, namely capturing patient data and sharing it with other healthcare professionals and patients. This was the foundational stage of the EHR incentive program. A is wrong because improving outcomes through higher thresholds describes stage 3, which came later as the program matured. B is wrong because stage 3 emphasized data interoperability and improved patient outcomes with increased thresholds, not stage 1. C is wrong because advanced clinical processes and patient portals are the focus of stage 2, not stage 1. Meaningful Use was the federal incentive program under high-tech that rewarded providers and hospitals for adopting certified EHRs and using them in defined ways. The program unfolded across 3 progressively demanding stages before being renamed Promoting Interoperability Programs in 2018. Stage 1, beginning in 2011, focused on capturing patient data electronically and sharing it. Stage 2, starting in 2014, required advanced clinical workflows and patient portals. Stage 3, from 2017 onward, demanded data exchange across organizations and measurable improvements in care. Think of the 3 stages as a staircase. Each step assumed the prior one was complete. You could not meaningfully pursue interoperability if you had not yet captured structured data, and you could not demonstrate outcome improvements without first establishing clinical workflows. The program's design was intentional. Rather than mandating specific software, policymakers defined measurable outcomes and let the market supply certified tools. Certification bodies like CTIT verified that EHR products could actually satisfy the criteria providers needed to meet. On exam day, match the signal phrase to the stage. Data capture and sharing points to stage 1. Patient portals and clinical workflows point to stage 2. Interoperability and measurable outcomes point to stage 3. Mixing these up is the predictable trap. Question 9. A primary care clinic notices that physicians override drug-to-drug interaction warnings in their EHR more than 90% of the time, often without reading them. Most of the alerts are low specificity and trigger on minor or clinically irrelevant interactions. Which clinical decision support phenomenon best explains this behavior? Your options are A. Alert fatigue, in which clinicians ignore frequently triggered alerts that are often clinically irrelevant. B. iatrogenesis, the introduction of new errors caused by EHRs. C. Workaround behavior, in which users circumvent a problem without solving it. D. Cookbook medicine, the perception that decision support reduces practice to a recipe. What's your answer? Commit to one before I continue. The correct answer is A. Alert fatigue, in which clinicians ignore frequently triggered alerts that are often clinically irrelevant. A is correct because alert fatigue describes the phenomenon in which clinicians become desensitized to and routinely override decision support alerts because the alerts fire too often and are frequently false positives or not clinically specific. A 90% override rate on low specificity alerts is the textbook signal. B is wrong because EI iatrogenesis is the broader category of new errors introduced by EHRs, including but not limited to alert behavior. The specific mechanism the question targets is alert fatigue. C is wrong because a workaround circumvents a system problem without solving it. While related, the specific term for habitually overriding low-value alerts is alert fatigue. D is wrong because cookbook medicine is a clinician concern that decision support oversimplifies practice. It does not explain habitual override behavior. Alert fatigue is one of the most important structural problems in clinical decision support. It describes what happens when clinicians become desensitized to alerts. Soxa or chiain. Not because they are careless, but because the alert system itself has failed them. The cycle begins when alerts fire too frequently and with low clinical relevance. Through a process called extinction, the brain learns to dismiss the entire category. Once that conditioning sets in, even genuinely important alerts get overridden by reflex. The core problem is signal-to-noise ratio. When irrelevant alerts dominate the system, the valuable ones become invisible. A well-governed alert system fires rarely and specifically, so when an alert does appear, it earns attention. The solution is alert governance, an ongoing organizational commitment to measuring, pruning, and redesigning alerts. Override rates are the key metric. High override rates signal low value, and those alerts must be restructured or retired. When a question describes clinicians ignoring alerts or high override rates, the named phenomenon is alert fatigue. It is distinct from EI iatrogenesis and workaround behavior. The fix is always systemic. Redesign the alerts, not the clinicians. Question 45. A patient safety officer reviewing electronic prescribing data finds that a clinician selected hydroxyzine when intending hydralazine because the names appeared visually similar in a long pick list. Which electronic prescribing safety strategy is most directly designed to reduce this kind of look-alike selection error? Your options are A. Big Bang Go live for medication modules. B. Computerized provider order entry without decision support. C. Tall man lettering, the use of mixed case lettering for look-alike medication names. D. Phased deployment of pharmacy applications. Pick one. Trust your gut. Here's your chance to test yourself. The correct answer is C. Tall man lettering, the use of mixed case lettering for look-alike medication names. C is correct because tall man lettering is the use of mixed case lettering on look-alike medication names, such as hydroxyzine and hydralazine, to make the visually similar names easier to distinguish in pick list and prescribing screens. It is one of the safety strategies endorsed for reducing look-alike selection errors. A is wrong because Big Bang Go Lev is a deployment approach for launching modules at once. It does not address look-alike name confusion. B is wrong because computerized provider order entry without decision support actually contributes to errors of this kind. It is not a remediation strategy. D is wrong because phased deployment is a deployment approach for staging implementation across units. It does not address look-alike medication name confusion. Tall man lettering is a typographic strategy that reduces medication errors, by visually highlighting the differences between look-alike drug names. The principle is simple. Make the differing letters stand out so the clinician's eye is drawn to them at the moment of selection. In standard type, hydroxyzine and hydralazine look nearly identical, especially in a long pick list under time pressure. Tallman lettering renders them as hydroxyzine and hydralazine, forcing the eye toward the letters that actually differ. These errors are stubborn because multiple factors converge. Prescribers face long lists of similar sounding names, often under significant time pressure. Tallman lettering attacks the problem at the exact moment of visual recognition during selection. The strategy was developed by patient safety organizations including ISMP and the FDA, and is now embedded in many EHR systems. It is one layer in a broader defense that also includes indication-based prescribing, decision support, and pharmacy verification. The typographic change is small, but even a fraction of a second of extra attention at the right moment can prevent a serious error. When you see mixed case lettering or visual differentiation in a question stem, Tallman lettering is the name strategy. Question 46. A health system is considering the executive position responsible for the overall information system strategy, final approval of major technology purchases, alignment of IS strategy with organizational strategy, and ownership of the capital budget. Which role best fits this description? Your options are A. Systems analyst who bridges application knowledge and the business domain. B. Chief Information Officer who provides primary leadership for the IS department. C. Operator who performs jobs within the operations section. D. Telecommunication technician who programs telecommunication switches. Which would you go with? Lock it in before the reveal. The correct answer is B. Chief Information Officer who provides primary leadership for the IS department. B is correct because the Chief Information Officer, or CIO, holds the primary leadership role within the IS department. Responsibilities include final approval of technology purchases, development of the IS strategy, alignment with organizational strategy, and ownership of the capital budget. I is wrong because a systems analyst bridges as knowledge of a specific application with the business function it supports. This is a technical functional role, not the executive leadership position described. C is wrong because an operator performs duties within the operations section of an IS department. This is a frontline role rather than executive leadership. D is wrong because a telecommunication technician programs telecommunication switches and patch panels. This is a specialist technical role, not the executive leader of IS strategy. The Chief Information Officer is the executive leader of the Information Systems Department in a healthcare organization. This role exists because technology decisions at a healthcare system scale require executive-level authority, accountability, and a direct seat at the strategic table. The CIO carries 4 core accountabilities: approving significant technology acquisitions, leading information system strategy, ensuring that strategy aligns with where the broader organization is headed, and owning the capital budget from proposal through execution. The CIO sits at the intersection of technology, operations, and strategy. Rather than managing just one domain, the role bridges all 3, ensuring that what the IS department builds and buys actively supports organizational goals, not just technical ones. A common exam trap is confusing the CIO with other IS roles. Directors lead sections, managers handle operating budgets within departments, and supervisors oversee hands-on staff work. The CIO sits above all of them as the sole executive owner of the entire IS function. When a question stem mentions primary is leadership, final technology approval, strategy ownership, or the capital budget, the answer is the CIO. These signal phrases point to one role because only the CIO holds all of them simultaneously. Question 47. A quality director presenting at a hospital board meeting outlined 6 principles for redesigning healthcare. The principles are safe, timely, effective, efficient, equitable, and patient-centered. Which framework do these principles come from? Your options are A. The 5 Cynefin domains, B. The 4 core values of extreme programming, C. The 5 stages of the STAR model, D. The STEP principles for redesigning healthcare. Don't overthink it. Which one feels right? The correct answer is D. The STEP principles for redesigning healthcare. D is correct because STEP is the acronym for the 6 principles for redesigning healthcare, namely safe, timely, effective, efficient, equitable, and patient-centered. The list in the scenario is a direct match. As is wrong because the Cynefin domains are simple, complicated, complex, chaotic, and disorder. They do not describe healthcare redesign principles. B is wrong because the core values of extreme programming are communication, simplicity, feedback, and courage. They are not healthcare redesign principles. C is wrong because the STAR model has 5 stages of evidence translation. It is a model of evidence-based practice, not a list of redesign principles. The STEP framework gives healthcare a shared vocabulary for quality. Developed by the Institute of Medicine in the landmark Crossing the Quality Chasm report, it defines 6 dimensions that should guide the redesign of clinical and operational systems. Each letter in STEP names a distinct dimension. Safe means care that avoids harm. Timely means reducing harmful delays. Effective means doing what works for those who need it. Efficient means eliminating waste. Equitable means quality that does not vary by personal characteristics. And patient-centered means care guided by individual values and preferences. Before STEP, improvement efforts focused on different dimensions in different places with no way to compare or aggregate results. The framework gave the field a single structure so that organizations could align, and so that informatics initiatives advancing multiple STEP principles could be recognized as higher priority than those advancing only one. When you see the 6 principles named together in an exam stem, STEP is the answer. Watch for distractors like the Cynefin domains or the STAR model, which describe entirely different frameworks and do not map to these 6 dimensions of healthcare quality. Question 48. An evidence-based practice committee is following a 5-stage model that begins with discovery research, continues through evidence summary and translation to guidelines, then practice integration, and ends with process and outcome evaluation. Which model is the committee using? Your options are A. The STAR model of evidence-based practice, B. The Cynefin framework, C. The Staggers and Nelson systems life cycle model, D. The unified process. Got a guess? Lock it in. The correct answer is A. The STAR model of evidence-based practice is correct because the STAR model frames evidence-based practice as a 5-stage cycle. The stages are discovery research, evidence summary, translation to guidelines, practice integration, and process and outcome evaluation. The sequence in the scenario is a direct match. B is wrong because the Cynefin framework classifies situations into domains for sense-making. It is not a 5-stage evidence translation model. C is wrong because the Staggers and Nelson systems life cycle model has phases like analyze, plan, develop or purchase, test, implement, maintain and evolve, and evaluate. Its purpose is system implementation, not evidence translation. D is wrong because the unified process is a software development methodology with 4 phases. It is not an evidence translation model. The STAR model is a 5-stage cycle that describes how evidence becomes clinical care. developed by Stevens at the Academic Center for Evidence-Based Practice. It gives researchers, reviewers, guideline developers, and implementers a shared structure for their work. The 5 stages flow in sequence and loop back on themselves. Discovery research generates new knowledge. Evidence summary aggregates findings into systematic reviews. Translation to guidelines converts those summaries into actionable recommendations. Practice integration moves guidelines into real clinical workflows. And process and outcome evaluation closes the loop by assessing results and generating new questions. Each stage has a distinct output. Early stages produce knowledge and summaries. Middle stages produce guidelines and implementation tools. The final stage produces evaluation data that feeds back into the cycle, making the model self-correcting over time. No single stage is sufficient on its own. Brilliant discovery research that never gets summarized, translated, or implemented never improves patient care. The STAR model insists that all 5 stages must function together for evidence to reach the bedside. In nursing informatics, clinical decision support sits squarely in the practice integration stage. It depends on rigorous work in every earlier stage and requires evaluation afterward to improve. Recognizing where a tool or activity falls in the STAR cycle is the key exam skill. Question 49. A health system implementing a new EHR plans to bring all applications and modules live across every facility on the same weekend, rather than rolling out one unit at a time. Which deployment approach does this represent? Your options are A. Phased go live, in which paper and electronic environments coexist during transition. B. Parallel deployment, in which old and new systems run side by side. C. Big Bang Go Live, in which all applications or modules are implemented at once. D. Walk-in skeleton, in which a thin end-to-end system is built first. Which one is it? Pause the video if you need more time. The correct answer is C. Big Bang Go Live, in which all applications or modules are implemented at once. C is correct because a Big Bang Go Live is the deployment approach in which all applications or modules are implemented at once, often across the entire organization on the same weekend. The scenario fits this approach exactly. R is wrong because a phased Go Live spreads deployment over time, often with paper and electronic environments coexisting during the transition. The scenario describes the opposite. B is wrong because parallel deployment runs old and new systems concurrently. The scenario describes a single weekend cutover, not a parallel run. D is wrong because a walking skeleton is a development structuring technique, not a deployment approach for Go Live. When an organization implements a new EHR, one of the most consequential decisions is how to deploy it, all at once or gradually over time. These two approaches are called Big Bang and Phased Go Live. In a Big Bang Go Live, every application and module launches simultaneously across the whole organization. Training, command center support, and vendor resources are all concentrated into one intense period, and the transition is decisive. The phased approach spreads deployment across weeks or months. Each unit goes live in sequence, so lessons from earlier sites inform later ones and problems can be contained. But the organization runs hybrid workflows throughout the entire period. Neither approach is universally better. Big Bang minimizes hybrid workflow time but demands enormous resources and carries higher risk. Phased deployment reduces that risk but prolongs the period when old and new systems coexist. On exam day, watch for phrases like single weekend cutover or all modules implemented simultaneously. Those signal Big Bang. The right choice always depends on the organization's size, complexity, and risk tolerance. Question 50. A nursing informaticist on rounds discovers that bedside nurses are bypassing a slow medication scanning step by scanning a printed copy of the patient's wristband taped to the cart, rather than scanning the wristband at the bedside. Which informatics term best names this behavior? Your options are A. Refactoring, the restructuring of existing code for higher quality. B. A workaround, a method used to circumvent a problem without solving it. C. Iatrogenesis, a new type of error introduced by EHRs. D. A walking skeleton, a thin end-to-end version of the system. Take a second. Which answer would you pick? The correct answer is B. A workaround, a method used to circumvent a problem without solving it. B is correct because a workaround is a method used to circumvent a problem in a system without solving it, often introduced by frontline staff to keep work moving. Bypassing a slow scanning step by scanning a copy of a wristband at the cart is a textbook clinical workaround. A is wrong because refactoring is a software engineering practice for restructuring code. It does not describe clinical bypass behavior. C is wrong because iatrogenesis is the introduction of new types of errors by EHR systems. While workarounds can contribute to iatrogenesis, the specific behavior the scenario names is a workaround. D is wrong because a walking skeleton is a development structuring technique, not a clinical workflow bypass behavior. A workaround is a method that circumvents a problem without solving it. Understanding why workarounds emerge and what they reveal is central to nursing informatics practice. Workarounds arise when real work cannot wait for official solutions. The nurse is not being careless. She is rationally responding to a system that makes the correct path slower, harder, or less reliable than the incorrect one. Every workaround solves the immediate problem the individual faces while leaving the underlying system problem in place. The local benefit is real and visible. The system cost, compromised safety, degraded data, misled colleagues is often hidden. Workarounds are not personal failures. They are signals about where the system is failing the people who use it. The right response is not stricter compliance enforcement, which produces more covert workarounds, but fixing the system so the right thing becomes the easy thing. When you see phrases like bypassing procedures, frontline shortcuts, or solving an immediate need without fixing the underlying issue, the named concept is workaround. The remedy is always system redesign, not enforcement.
You have reached the end of our first question set. For the free complete exam preparation, visit our website, link in the description, where you find thousands more practice questions and comprehensive study guides. Thanks for studying with us today. See you in the next video.